earlier where we were talking about our C2 medications. We're talking about any of our controls for the most part, especially our C2s. Those are the most restricted medications that we had. Remember, we were going to do no refills with them. Most of them are 30-day supply, unless it's a maintenance medication, then we can do our 90-day supply with those. But again, no refills. Now, these are typically going to be written prescriptions. There are emergency situations where you can fax over a prescription, or sometimes like you can call them in. Typically, we try to get them faxed because then we know that it's coming from a doctor's office, because most people don't have a fax machine. But in Florida, we used to have a lot of hurricanes, and so we would use this a lot, right? Because people aren't going to be out. Or if you work next to like a hospice center, so the Walgreens that I used to work at, it was next to a hospice facility, and so we used to do this a lot where we would take their exceptions to those C2s and how we receive the C2 medication. So in an emergency, like I said, we prefer them to be faxed, but if things are down, then of course they can telephone in the prescription. And typically when we're receiving these telephone prescriptions, they should only be good enough for the time of that emergency. Right? So we're not giving them like a full 30-day supply. We're saying like, hey, we're expecting for this emergency to happen for, a week or what have you, or 3 days. After that, people should be able to go back to the pharmacies or go back to their jobs, what have you. So you're not giving them the full quantity that you would typically be giving them for their medication, okay? So this is just to get them by through that emergency situation. When you see this, again, we cannot do anything that is exceeding that period, and then within 7 days, the provider, which would be you, should be mailing me, the pharmacy, a prescription. And then I go back and I use that as like, okay, here's the actual signed prescription, and that's what I file, so that when I have my DEA inspections, I have my hard copy still, okay? So the one that I take over the phone, I'll take it, I write up the prescription, and then I put it to the side, and I wait for you guys to mail it to us, and then we staple that together and we'll file it to say like, hey, we did actually get the hard copy prescription, the doctor followed the protocol, okay? Looking at our exceptions to where you don't have to then follow up with that 7-day period of the hard copy, these are situations to where that fax prescription will serve as my hard copy prescription for my filing, okay? You don't have to follow up and mail me anything. So this is like outside of my emergency situations, okay? This is when I can accept a fax instead of a hard copy. So the first one is if I'm going to directly administer that medication that is compounded by the pharmacy to a patient. If I'm doing that, then I don't need to follow up with a hard copy. That fax is going to be good, that's going to be my hard copy. I will file that in my pharmacy records. If there's somebody who is in a long-term care facility, and that could be something that is like the hospice center that was close to us, or like a long-term care facility that just essentially takes care of your elderly patients sometimes. So they get put kind of in like a nursing home. So that you can see where they're gonna, the dispensing pharmacy will directly have those medications, and they'll take care of that. That fax then still serves as the hard copy. And then for your patients, again, in that hospice situation, or if they have their medications that are being paid by Medicaid, then we can also use the fax as the hard copy in that situation. So long-term care facility, hospice, or if we're going to compound it and we're giving it immediately. Those are your exceptions without like several words, okay? So long-term care facility, you're compounding it and they're going to immediately get it, and then your hospice patients or the Medicaid. This was that accountability that we talked about, right? So when we're here, stateside is my responsibility. You don't have any responsibility. I'm gonna go check your floors, I'm gonna check your Pyxis machines, I'm gonna do all of that. There are situations sometimes where staff may be limited, and you may be involved, or the nurse may be involved with helping maintain our counts. But the pharmacy is typically going to come by at least once a month still to try to check in on those drugs to make sure that y'all aren't like having some kind of like ring or something. So we typically still step in, but most of the time this is going to be on you. If you're deployed, definitely on you, Okay, so that's what I was telling you, just make sure that you're keeping an eye on it, that you're still doing your counts to make sure that you are not going to be on the hook for something that somebody else was taking or using incorrectly. Make sure that your files are properly there. You document, you know where everything went, your logs are up to date. Like, this is going to be a big deal, because if those counts and everything are off when you get back, or even if, because we are also deployed, pharmacists can also be deployed, if we end up going over and doing a check, or if sometimes some of the units will say like, hey, can you come over and do a double with us? And we'll double check their counts. Like, if anything is off, you have issues, okay? So just make sure that you're strictly following all of your guidelines that you're gonna have in play whenever you go downrange, and that you are keeping a close eye on your drugs. All right, our drugs and pregnancy. So when we talk about pregnancy, you may be the first line that tells a patient, hey, you're pregnant. They may not know. You may be doing labs, and then you're gonna be like, oh, I got a little surprise for you, okay? It is going to be your job to look at what other medications are they on. What medications do I need to take them off of because it could harm their child? What medications can I use instead of that until they get to their OB appointment? Because you just told them that they're pregnant, and OB may not be able to see them for a month or two, or they may tell them to wait. Like, oh, when was your last menstrual cycle? Oh, it was just 2 days ago. Cool, we're gonna need you to wait to come in. Even though your pregnancy test came back positive, even though we hear of people, being very pregnant while they're having a menstrual cycle still sometimes, like, you still are gonna be that first line defense. So if you pull a medication because we know that it's gonna be harmful to the fetus, you need to be putting them on something else, okay? Don't just take them off of something like if they're on a high blood pressure medication and be like, well, you can't have this ACE inhibitor because it's bad for the baby, and then you don't put them on anything. You have to still control their blood pressure, okay? So then you need to look and say, all right, what other medication can I give them that is safe whenever they're pregnant? Oh, I can use labetalol instead. Cool. I'm gonna put them on labetalol, okay? So this is just showing you that there's different periods that are gonna be very important while the fetus is developing. I don't need you to remember them all. I'm gonna tell you what I need you to remember, and it's not this slide, okay? So let's go to the next slide. When we're looking at this, the most important thing that you're looking at is understanding that we are trying to protect the fetus, but we also have a patient, right, who is here now that you have to take care of. So it's always risk versus benefit. Even if someone is not pregnant, you're always kind of looking and you're saying, all right, what's the risk versus the benefit of me giving this medication? Okay? It's not black and white. Medicine is not black and white. You have picked the most rewarding field, but like when you want to just look at a paper and you're like, what do I do? Sometimes you don't get that answer, because that person who's standing in front of you on the other side of that paper might be super complex. And you're like, well, what can I give you? Right? Like, nothing is working. What else do I have to give to you? So just pay attention. Make sure that you're asking if they're breastfeeding. That's another big important thing. So even after the baby comes out, we still have to maintain that that whole like picture of what could I be affecting outside of just the patient in front of me. Okay. So when we're looking at the first and the early stages of pregnancy, so within that first 2 months of pregnancy, you can see that a lot of gross abnormalities can occur depending on some medications that we could potentially give our patients, okay? So when we start to go through different drug classes, you'll see where I'll say like, that's teratogenic, you can't give it, okay? Teratogenic means it's gonna harm that child, whether it be make them, the mother abort, or they have like some gross abnormality, their cleft palate, like there's so many different things that could occur, okay? So when we're looking at this, just make sure that you're understanding that I can give a drug and it can affect the baby. It's not just gonna affect the mom. Not all drugs will affect the baby. Some of the drugs that we're gonna go over, you're gonna hear me say like, oh, it's okay in the first trimester, but not in the second and third. Or, oh, avoid it in the first trimester, but they can have it in the second or the third, okay? So it will depend on what drug class we're looking at. All I want you to look at is what is in bold, okay? Just understand that when you're looking up your drug information, you're going to see when it is safe or not safe to give a patient a medication while they are pregnant. I don't need you to remember the stages. I don't need you to remember any of that. When we get to those drugs, I will let you know. For this exam, all I'm expecting for you to understand is that depending on what stage that baby is in development, I can give a drug and it could potentially affect that baby in that stage. Okay? I know this is a lot of like terms. I'm not going to ask you anything like that. Yes.
So, and would it be straight to summarize it, kind of just be like, hey, the first 8 weeks generally is where the baby is most vulnerable to potential teratogenic effects.
Yes and no, because depending on what drug I give, some of them I can make it all the way to my last trimester. You give me that drug and you can make me have an abortion. You can make me go into labor early. So like, yes and no, right? It just, and that's why I said I'm not asking you a question like this, because every drug is literally different. And it's very confusing, and on some of the drugs, when we start going over slides, I'm gonna tell you, don't worry about that, send them to OB. It's not your problem. Because it gets that confusing. It's like, okay, you can give it in the first trimester, not in the second trimester, and you can give it again in the third trimester. That's a lot, right? And after they get to OB the first time, they're not coming to you again anyway. So I just want you to be aware that there's meds that you're gonna have to pull off whenever you do their med rec, whenever they find out they're pregnant. And then there's meds that you could potentially prescribe a patient that could harm their child. The stage that they're in is going to continue to progress, and the effects of our medication could be very harmful, or if it's later in pregnancy, it cannot be so harmful. We don't know, it depends on the med. So that's why I don't really, I summarize it a little bit different, but yes, it just depends on the med. Okay, this was pre-PLLR. And this was the way that we would categorize medications, right? So we would look at a package insert and we would say, hey, what drug category is this? Is it category A, B, C, D, X? Like, what can I use this safely, essentially, in a patient who is pregnant is what this was for. And you will still hear a lot of providers refer to this, even though we're not supposed to use this anymore. I still do it. Lots of people still do it because it's a lot cleaner. And we remember it. A lot of drug companies no longer print, well, some of them do, but some of them no longer will print with the drug category. So the way I want you to remember this is if you see category X, that means no, okay? We're not doing it. It has shown that there is some type of abnormality or potential death that happened to that fetus because I gave that medication. So a category X means I'm not giving it, stop. Okay? Category A is our best case scenario. I haven't seen anything, there was no harm, this medication is golden, A+. Okay? As you go down from A to D, you start to see that like there's increased studies or there's no studies. So typically when I'm practicing and I hit category C, I won't give it to my pregnant patient. Because my category C is telling me like, hey, I saw some stuff when I was studying it on animals, but I didn't really see anything when I was studying it on humans, or I don't even have a study that tells me what happens in humans. I'm not messing with it. So anything that's like C down, if somebody is pregnant, I typically won't touch it. I won't give it to them. But A and B are like, okay, we can kind of deal with it. You're not gonna see a lot of studies on pregnant patients because nobody wants to volunteer themselves while they're pregnant, right? Like, you can, I do not volunteer myself as tribute, okay, if I'm pregnant, right? Because I have this human, so what happens if that drug is teratogenic? And now you did this study on me and I lost my baby, right? So that's why we won't see a lot of these. You will see a lot of post studies or like reviews that we'll have on them, but you won't see like a double-blinded control, like randomized controlled study because somebody is like, I'm not gonna let you go my kid, right? So that's why we kind of see this. So depending on what the drug is, and sometimes I'll go and I'll just read literature and say, hey, like, what does it say? Like, what do these reviews say? Because there are lots of people who are pregnant who take meds off-label or who take meds because they didn't know they were pregnant, and then we get that data and we say, hey, like, how did their kid come out? Was it okay? Cool. And we start to pull that together, okay? Yes?
What does PLR stand for?
PLR stands for pregnancy, lactation, and labeling requirements, okay? So this is PLLR. And essentially what these are the new categories that replace the A through X, okay? A, B, C, D, X. A, B, C, D, X. And so now what you see is you have a pregnancy, a lactation, and a female and male reproductive potential, bless you. And so with that, what they're doing is they're like, all right, hey, if you're pregnant, can you take this medication safely? If you are breastfeeding or you're lactating, can you take this medication safely? If you are trying to become pregnant, can you take this medication safely? Or get someone pregnant, can you take this medication safely? There's still not a whole lot of studies on the male reproductive potential being affected. Most of the time we always look at females, but a lot of the drugs are starting to come out where they do look at this, yes.
Are there any drugs that are only harmful to the mom but not the baby?
Some yes, but if it's harmful to the mom and I die and my baby is, well, unless you're in Georgia and they keep you alive to deliver babies, but if something happens to the mom, right, like you have to think about it like a host and a parasite, right? If the host dies, the parasite has nothing to feed off of, right? So the mom is the host and the kid is the parasite. Legal, they are for the rest of their life. I'm just kidding, I love my kids. I'm still my dad's parasite, he still pays my food bill. Just saying. So, how y'all get me here? How did we end up here? So whenever I'm looking at it, right, what you have to think of is like, legally we're in a sticky spot right now, right? Because you have different states who have different laws. And something could happen to me, I could be brain dead, and they could keep me on a machine to keep my body functioning to where I can create an environment for me to deliver a baby, right? I'm considered now at that point like an incubator type, right? Versus if something happened to me and I passed away, if no one found me soon enough, my baby is also gonna pass away, right? So, like I was joking, but like the climate, political climate has a lot to do with all of this stuff too. So yes, there are meds that could be harmful to just me and not my child, but ultimately anything that harms me can potentially harm my child. If my blood flow drops, now my blood flow to that fetus is gonna decrease too, right? So now what's gonna happen to them? Kidneys could be affected, brain could be affected, their growth could be affected. So like there's a lot of things that they're connected, but it could be like an indirect harm now to the fetus, not necessarily a direct harm. So there are drugs that you can take that don't necessarily cross the placenta is kind of, I think, what you're asking, right? Like that don't go that way, yes. But if something, even lactation, right? I could be breastfeeding and taking a med that does not go through my breast milk, okay? So everything doesn't have to pass through, and some things that do pass through may be very minute to where it's negligible, it doesn't matter. So like for me, I don't take pain meds after I have my kids because I want to breastfeed and I don't want them to have it, right? So that's my choice. But you can safely take pain meds and breastfeed your child. And the amount that they give is minor, but I'm also crazy, no, I'm just kidding. I'm not in enough pain to where like after I have the C-section, it's like cool, like let's go, I can move around, I'm fine. And I want to be alert, I want to be awake. So this is also like a choice thing because you will have some parents and some mothers who are like, I don't want my kid to have anything, any med, and they will choose to not take medications. And you have to respect it. You can educate, you can talk to them. This is like y'all will talk about stuff like this and like med ethics, but this stuff comes up all the time. Where like someone's like, I don't want to treat that. I don't want my kid to have that, right? And you just have to say, yes, but blah, blah, blah. You're gonna explain to them and then it's up to them. You do what you can and then your hands are tied. So yes, there are some of those meds that can do that. When you're looking at these, I want you to pay attention to your pregnancy and your lactation. You see that you have 3 subcategories in there. Risk summary, your clinical considerations, and then the data that they have for them to be able to draw the conclusions that they did. You will get to see all of that. So you look these up and it gives you all of this information. When we're talking about the reproductive potential, just understand that these are things that could affect fertility. But like I said, when we're talking in regards to our males, there's not a lot of data on like if I were to get a female pregnant, how much of that drug that I was taking would be in my sperm that could affect the fetus whenever like the egg and the sperm conjoin. Okay, so like just be aware that when we go through drugs, it's going to be very heavy on like what the woman can't take during pregnancy. And then we have a couple of drugs where we'll actually look at it and they'll say like, oh, even if a male is taking this, they can't get someone pregnant for X amount of weeks or for a month. Or it'll say like, hey, if a female is taking this, she needs to have 3 menstrual cycles before she can get pregnant. So you'll see different things like that. That's what this packet will tell you. Okay, how can you safely give a patient a medication without them disrupting one of those critical periods of development. So without disrupting this, can I treat my patient? Okay. All right, regulations. So there are key regulations that we have that have said, hey, this is why pharmacy is the way that it is. This is why we prescribe the way that we prescribe. We have to follow these rules, right? So when you look at different things, this is just the history of kind of what has shaped where we are. So the 1906 Food and Drug Act, essentially what this is saying is like, are the drugs prepared the correct way? Are they not adulterated? Like, is the formula only including what it says it does? Like, it's not Coca-Cola with cocaine in it, is it? Like, or is it? So that's what this is. Like, Food and Drug Act is saying this is the only things that are in here are what is listed on this label. There's nothing that should not be in here in my medications that I have, okay? The Harrison Tax Act, so when we look at this, essentially what they did was they made it more difficult to distribute opioids because there was starting to be abuse, which now we know is a huge, huge problem. So essentially this was just trying to cut down on it because now you have to pay tax. When people have to pay money, they don't want to, right? But now they make so much money off of it, it's like, okay, well, whatever. 1927 Food, Drug, and Insecticide Administration. So when you're looking at this, this was essentially the FDA regulating the food and the drugs, making sure that, again, they were safe for the community to have these medications without any type of adulteration or anything like that in them. So this is just giving us some like oversight to what we are ingesting into our bodies when it comes to our drugs and our food. The Food, Drug, and Cosmetic Act, so looking at this, this was just making sure that things were safe and effective before they came to the market. There was a lot of poisoning that occurred, primarily some kids after parents were, or the mothers were taking medication for, I believe it was nausea and vomiting. And so this is like one of those things that kind of made us realize like, hey, we need to make sure that that drugs are safe, that lids and things can't be opened easily. Okay, so this was just one of those things where we were like, we need some type of act to regulate this because 107 people died from taking a medication. All right. Alberti, or 1950, Alberti food products versus the U.S. And this drugs were misbranded essentially, and so what that means is that the directions weren't good enough. And so we have to make sure that the directions on how to use something, especially if it's over the counter, is good enough to convey that message to the patient so that they can take it safely. Okay? So like take 1 tablet by mouth every day. Or you'll say like do not exceed the maximum amount of 2 grams, right? So like our label has to tell me exactly what this drug is to be used for and how am I doing it, and it needs to be on the label. The Durham-Humphrey amendment, when we're looking at this one, it's essentially just saying like, all right, what's considered a prescription? Okay, is this a prescription or not? And then if you look at any label, you'll see that it says RX only, or you'll have that caution sign on there, like you're prohibited to have that medication without a prescription. It could be a felony. All those things are kind of like really small on most of our labels. On all labels, it should be of a prescription that you write. And so when our labels come out of the machines in the pharmacy, they have this already pre-printed on them. the 1962 Harris Amendment. We're looking at this. This one was the one that occurred due to the thalidomide. And so thalidomide was used for morning sickness, and they did not show that it was effective. And this was in Europe. And so what ended up happening was all of these safety and efficacy concerns, which now we look at in phase 2 of clinical trials, they caused these children to come out with all these deformities. And so they were kind of studying them, and then what they realized was like, oh, all of the mothers took this medication for morning sickness. And so now you have these kids that are living with these things, for the rest of their lives. So thankfully they didn't pass away, but this could be just as bad and debilitating, right? 1966 Fair Packaging and Labeling Act. This was essentially so that you know what you're buying. Again, right? So now you see like a lot of this is like, are we telling the people exactly what they're buying? Are we making sure that these things are safe? Are we making sure that these things do what they say they're going to do? Like, am I educating this person so that they can make a decision on what they're putting in their body? Like, am I giving them the full picture? And is it a true picture? 1970 Poison Preventing Packaging Act. Sorry, y'all, my nose is like, I don't want to blow my nose in front of y'all. Be right back, because I can't talk. All right, sorry. So your Poison Prevention Packing Act. So this one was just, again, making sure that we have child-proof packaging. So what that means is when you see the vials of prescriptions, we have, yes.
Sorry.
No, you're fine.
I was just trying to go back to 1938 and the 1962. Like, what differentiates the two? Like, was it not effective in the beginning where we had to show that it was safe for marketing? Then in 1962, that amendment came out, but it kind of seemed like the same thing.
Yeah, but more detailed. Like it's amending what we had in 38. So like, oh, sorry. So when you're looking at this, right, this is like when we say like a knee-jerk reaction. Something has to be done because we had all these people die. So I'm gonna put something in place that says like, hey, it's safe before you like put it to market. When we look at our amendment, it's like, yes, it has to be safe. It also needs to be effective. So like they built upon what we had already did in 1938. Because safety and efficacy are two different things. Safe is saying like, it's not gonna hurt me, I can take it. Effective is it doing what it said it's gonna do? Like, is it working? Okay, so like they made it better than what it was and not as vague. Because initially we panicked. Right? We're like, what can I do to make sure this doesn't happen again? And then as time goes on, you'll start to see like, oh, there's a hole here. I need to make it better. I need to patch it up. So that's kind of like what they do with our amendments that can continue to happen. Which one was I doing? Poison prevention. So when you look at this, think about your prescription vials and how you have to like press the thing down and then twist the cap, or you have to press it down and twist it. Like there's something that is gonna make you do. You can't just go and open it, right? That's so that we don't poison our children. Now, there are exceptions to this. If you have somebody who's handicapped, if you have an elderly patient, if you take one of your prescription bottles, typically, depending on what pharmacy you go to, and you flip the lid upside down, it turns into a twist top. instead of like a safety where they have to pull it down and push it down and twist it, okay? If they request that in the pharmacy, we can do that for them so that they don't have to struggle that first time to take it off. You can also write that in the notes for us in the pharmacy for us to do that before your patient even gets to us so that we know, hey, they're okay with not having the child food. If it comes in one of those stock bottles that you have to push down and twist, you can take it and put it on the ledge of a counter and you hit down on it and it'll pop that top off and then it just becomes a twist top. You don't have to push down and twist, okay? So when we do that, or if you help your patient do that, you need to make sure that they are locking that medication away from children because now you don't have that security, okay? So it's a possibility, but we still need to tell them, like, make sure this is out of reach of kids. Yes,
You said the exceptions can be done.
elderly patients, because a lot of times they can't, the mechanics to do it, okay? I could also be a regular person, tell you I don't have kids or I don't care about my kids and I don't want that top. And you can do that, okay? You can always do that, but you need to document, be like, I counseled them and they told me, because you don't want them to come and say, oh, they did this and I didn't know, okay? 1970 Controlled Substance Act. This is a big one. This is where we got our categories, our 5 categories. We talked about this yesterday. And then the DEA is going to be the ones who established it, and they're also the ones who monitor it, right? So anytime we think about a controlled medication, we're always thinking about the DEA, right? This was their baby, the Controlled Substance Act. 1984, this drug price competition and patent term restoration. This was what I was telling you about before, with like if you have a patent and you're allowed to have that patent and nobody else can have that name, and so they have to wait until the patent runs out whenever you bring a drug to term or to the market. They have to wait and then they're allowed to use that generic. So depending on what's going on, sometimes and what type of drug it is and what disease it's treating, you can have where that patent can be shortened, you can have where it can be extended. It just depends on what's going on. So that's what this is talking about. So just remember patenting and allowing for generics to kind of come to the market a little bit quicker. 1990 Omnibus Budget Reconciliation Act, or OBRA. We used to call this OBRA 90. So this requires any pharmacist to counsel patients who have Medicaid. So now they're like super strict with it, where like a pharmacist most of the time will have to like come to the register with their badge to scan it to say like either they counseled the patient or the patient denied to be counseled, right? So I can go up there and say, hey, I see this is a new medication for you. Let me tell you about it. I don't want to know about it. And I go, okay, decline, right? But I have to document it and that gets reported for any of our patients who have Medicaid, every single one of them. The 1990 Anabolic Steroid Control Act. This was just us talking about steroid use in children and athletes and the potential abuse of it. So that just made us kind of scrutinize them, make sure that we're monitoring them a lot closer so that we don't have that abuse occur. And then HIPAA, which a lot of us know about, right? Health Insurance Portability and Accountability Act, and making sure that we're keeping patients' information safe. When you talk about HIPAA, make sure that when you're in phase 2, when you're practicing, don't just go in the hospital and like talk about things or pull up pictures on your phone and show them where other people can see them, right? Because you never know who's around you. You never know. I had a preceptor who told us a story about a patient they were passing away, but the family wasn't notified of what was going on yet. And they were talking about the patient in the elevator, and the patient's family was in the elevator. So if you can imagine, like granted they didn't say the person's name, right? And like technically HIPAA wasn't violated, but in a way like you did, right? So just always be careful. Don't take pictures of things or people without them knowing and then like share it around. Like that's stuff that can get you in trouble. That's your license, okay? So protect it. Don't just throw away papers or your notes when you're doing rounds with people's information in a regular trash can, right? Because it has their birthday, it has a lot of HIPAA and protected information on there, their diagnosis. Make sure you're putting it in a shred bin, okay? Big deal with HIPAA. And hospitals definitely follow it around a lot. All right, yes.
For our patients that are actually ill,
in like their abbreviations, or I'll put a room number, right? Because that room number is always gonna change, like a new patient will always be in there, but you're gonna have to keep track, right? So you have to pick how you're gonna wanna do that. When I used to round, I would print out the sheet and like write on the paper, and I would keep them for the next day. Like I thought, I'd lock it so that the janitors or whoever can't just go and find the patient's information. And then the next day I take it out and I print a new sheet and I'd be like, all right, that patient discharged, this person died, this lab changed. So you can do it on your iPad, or you can, you'll figure it out. It's a rough period, but you figure it out. You're like, do I like my iPad or do I want paper? I went real old school real quick and did not use my paper. I use my paper and not my computer. Okay, formulary. The formulary, if you are working with an EMTF and your patient stays in the MTF, is not super difficult. When patients don't want to come to the pharmacy and they want to go on the outside because they say, I waited in the pharmacy for 5 hours. Like, okay. Sometimes they give me a long time, but not 5 hours. Formulary becomes a very, very big deal, right? Because formulary, when you think about that, think about money. Think about what is the insurance gonna pay for this medication? What is the copay now that that person is left with, okay? There's different tiers, and then that is what that person is gonna have to pay, right? So some people, if they are elderly or on a fixed income, or they're in poverty, like all of these things become a big deal and this matters, okay? You have some people who are as rich as a skunk and they still don't want to spend their money, okay? They're frugal. I like that word because my dad said, don't call me cheap, I'm frugal. I was like, you're cheap, okay? There are some people who feel like, I served in the military, I'm a veteran, I should never have to pay for my meds. They're gonna wait in the pharmacy for their Tylenol for an hour instead of going to buy it. They're gonna wait for their ibuprofen, and we just don't argue, okay? So you educate. You educate them to let them know you can potentially have a copay if you do not go to the pharmacy at BMTF. If they come here, they're okay. If you're active duty and you choose to go outside of the MTF, you don't have a copay. But if you are a beneficiary, you can have a copay, okay? So make sure you let people know that. If they want their prescription sent somewhere else, they could potentially have a copay, unless they're active duty. Active duty, we're always free, okay? This is an actual link for you to be able to go to the TRICARE formulary website. And what happens is, and if it changes sometimes depending on if we're TRICARE East or West or whatever they want us to be that day, and you type in the name of the drug, it'll ask you like the person's gender, it's gonna ask you their age, you type in the name of the drug, and it will tell you, hey, this is how much this medication will be. It will tell you if it's not covered. It will tell you if you need to do a prior authorization, it's gonna tell you everything. So that's what we're gonna talk about right now. This is a very important topic, so please pay attention to this because lots of people get mad at you and me when we talk about formulary. All right, so uniform formulary is essentially like, think about you're at a restaurant and it's the full menu. It's everything that you have available to choose from. So when you get into phase 2 and you get on the computer and you get a Genesis, you can order whatever the P&T committee has said that you can order. Full menu, your pick. Hopefully it matches the diagnosis, okay? But you're gonna pick that med. That is your uniform formulary. P&T committee gets together. We have local P&T committees at hospitals, but we also have like a DOD-wide P&T committee because we're trying to make everyone look the same, okay? It's not gonna be perfect because different hospitals have different services and we have to cater to the services that we have, okay? But they're very similar. So when you're looking at this, you'll have a tier 1 and a tier 2. Your tier 1 is the lowest one, the cheapest one. Those are your generic drugs. My generics are always cheaper. My tier 2 is gonna be my brand drugs, right? I have to pay for the real thing. Now, when we talk about this, because you're gonna hear people tell you this, a brand and a generic is the same exact thing. One just has the brand name patented and the other one does not, okay? The formulation of the medication is exactly the same. I have had one instance with ADHD meds where the generic and the brand work differently for a patient. they were that sensitive to it. And you will have some patients where that it does occur, okay? If that occurs, you're just gonna write brand medically necessary on the prescription, or you'll write DAW, dispense as written. That's one of those abbreviations that we saw. And then that makes the pharmacy have to give them the brand because you said so. If you write for a brand and you don't put that, I'm gonna make that a tier 1 drug because I have to save us some money. So I'm gonna automatically switch it to a generic. So if it is a reason, you can write brand medically necessary on there or dispense as written, and we have to dispense it that way, okay? So that's the difference between your generics and your brand. You write brand on there and you don't write that I have to dispense it that way, we're gonna change it to generic. By law, that's what we're supposed to do, okay? And then you see all agents not selected from your uniform formulary are considered non-formulary, okay? So you have uniform formulary and then your non-formulary. That's anything that is not on there. Now, your basic core formulary are things that an MTF is going to be required to have to make sure that your patients have access to them, okay? It should be the absolute necessities that are there, okay? So that's your basic core formulary, the basics, right? You're going to need some medication for hypertension because most of our patients have hypertension. You're going to need meds for pain. People are in pain. Diabetes, like the asthma, right? These are basic things that we need. So those are going to be on your basic core formulary. And what we're trying to do is, like, if we were throwing out a net, we're trying to capture as many people as we can with our BCF, okay? So that is your basic core formulary. If you're at like a small clinic or a specialty clinic, sometimes you don't have to have this, okay? They're not required to keep them there. What you would do is you would say, hey, you have to go off post, or you could go to wherever our parent hospital or clinic is, okay? Because we have like little remote areas and sometimes they don't have enough space, okay? So that's why you see that exception there. Our extended core formularies, when you're looking at this, this is like I have some type of specialized clinic. Let's say you have an oncology clinic, everywhere doesn't have that, right? So then I need to make sure that I have those beds for those patients who are gonna come outside of that clinic. Because I can't have a service and not have the medication that my providers are gonna prescribe from that service, okay? So if I offer the service, I need to offer the beds. So that's where you see that extended core formulary, okay? So any of the meds that are not on your basic core formulary, but you offer that service there, they need to be provided as well at your installation. And so that's what you see there. MTFs must carry ECF medications if they have a specialty clinic that might prescribe them. If you're gonna prescribe them, they need to be available, okay? Even if it's something that we don't have readily available in the pharmacy, we would need to order it and get it to you pretty quickly. Yes?
Yeah, we're talking about PNT committees. I know that you kind of specified it's MTFs, but what about like Rule 3s like in the field hospitals? Like, would there be PNT?
No.
No.
Y'all just kind of do what you want to do. And you try to figure out, it depends on where you're going to be at, right? Because what are your capabilities? Essentially is what it boils down to. Like, do you have a fridge? Do you not have a fridge, right? Because some meds have to be refrigerated. So you kind of come up with what your list is going to be beforehand, and we have it kind of stocked in the fridge. Y'all will have different things in the fridge. In the pharmacy, our makeshift pharmacy, and then y'all will have your kits as well. And then we can order from a supplier over there as well. What they have and how long it takes to get them will depend on, like, at that time, like, if we are in combat, like what that actually looks like could be interrupted, right? Because if I can't fly stuff in, if I can't get it in on a ship, we're stuck. We landlocked at that point. So it's kind of like what you had when you went over there is all you're gonna get. So we do have different suppliers in different parts of the world to get us whatever you need, but it's not a P&T committee. It's kind of like, what do your soldiers need in that environment downrange? So that will vary. That's different. That make sense?
Yeah.
Okay, we talked about extended core. All right, non-formulary. So when you're looking at, let me go back real quick. So this, I was telling you, like, think about this as, a patient or a person who's like, they're in a restaurant and they say, well, I need gluten-free, or I want cauliflower pizza crust, right? Like, we're trying to offer it to this person because they have this allergy. So it's on our menu, it's an option for them, so that we can make sure that they're taken care of. Because now we have a lot of people who are like gluten-free, right? So if you want to be a successful restaurant, you should have some gluten-free options on your menu. Is essentially what this is. Your non-formulary. This is like a medication that is excluded from your formulary because it's not maybe the most cost-effective or the most common medication that somebody would use, but it will probably require a medical necessity form to be filled out by you, or a prior authorization form to be filled out by you. So when we talk about a prior authorization form, essentially what that is saying is like, you're saying they need this medication, it is appropriate for whatever their health condition is. And you're like, duh, I wrote the prescription. But TRICARE is like, duh, we're trying to save some money, okay? So prior auths get patients really upset. And if you want to, if it's a drug that you're not used to typically like prescribing, just go to the formulary lookup tool and see if it's gonna require the prior auth. Because then you can do it ahead of time. You can send it to TRICARE so that by the time they get to the pharmacy, we could like run it and say, oh, okay, cool, everything's been done. Because TRICARE will have that prior auth. If not, it's gonna reject, they won't know why, then they'll wait in the pharmacy, and then we'll call them back up and say, hey, you need a prior authorization, we're trying to call you, you're in the room with another patient. So if it's something that you don't typically prescribe, you're probably gonna need a prior auth for it, okay? So just look it up and see, because that's why you don't typically prescribe it, probably because it needs a prior auth. You're also gonna prescribe lots of meds that require prior auth, so you're gonna know. So like Viagra usually is gonna either have a prior auth or a medical necessity form to it, especially the younger the person is. They're gonna be like, why do they need this? They're 28. So they'll make you fill out either a medical necessity or a prior auth. When you think about the medical necessity form, I want you to think about money. I want you to think about a copay. So you're saying that this is medically necessary for this patient, and what happens is, if they're going on the outside, their copay, instead of being $50, might go down to $25, because you did the medical necessity form. You're like, hey, they actually, like, they do need this one, okay? And I know it seems counterproductive, but this is an insurance thing that has been around for forever. If we want to eliminate the back and forth, you want happy patients, you want the pharmacy to not call you and bug you. If it's something that doesn't seem common, look it up on the TRICARE formulary tool and say, hey, does this require a prior auth, and just knock it out. If you don't want to do the prior auth, prescribe them something different that doesn't require a prior auth, and then you don't have to do it, okay? But if they need that one, then you can go ahead and do it ahead of time and send it in. Yes?
Is that just a quick form that you submit? Or?
Yes. And so when you look at a prior auth, it'll say like, all right, you want them to have this med. Have they tried this before? Have they tried this before? Like, they want them to try cheaper alternatives or medications that they have a lot of data on before they give you whatever that other newer med is that costs more. So it's like an algorithm that you're kind of going through, and it's like if you say no, stop, they can't have this medication. They don't meet the qualification. And then you have to change it anyway. Right? So that's why patients get upset with prior auths, because they come to you write down a prescription, you think everything's good, they come to the pharmacy, I actually run it, and then it's like, nope, need a prior auth. Now I have to get you back, then you do the prior auth, we send it out to the insurance company, and they're still like, no. Your patient is like, I just waited 2 or 3 days for what? And now you're having to change the med. So it's frustrating for all of us, because then you're like, great, now I have to find something else, and then y'all usually call us and be like, what else can I use? I'm over it. So that's typically what happens. We usually switch to it. But prior auths, they're not that bad. They're very simple forms, but if you don't know that you need a prior auth, that's where it becomes a problem. It should take you maybe a minute or 2 to fill it out. And all you're doing is looking back to say, yep, they tried that before, yep, they tried that before, and if they didn't, you put them on those meds, you make them trial them, and then you can go back to the prior auth again later if those meds do fail. Okay? All right. Let me finish this slide and then we're going to take our break. When you're looking at this, that second bullet where it says can be provided at the formulary cost share of the provided supplies the information for the medical necessity. That was all I was telling you about with the copay, right? So we're making sure that if we have a higher copay, we fill out that medical necessity form, we're helping out the patient. So medical necessity is money, prior authorization is saying it's appropriate. Okay, so our PA is saying it is appropriate, whereas our MN is talking about money, the copay. Okay? And then remember with your highest copay you have is tier 3s. They're never really covered sometimes. We also have tier 4s that are absolutely not covered. So we'll go over a picture whenever we come back for break. All right, 10 minutes.
What medication have you tried?
Like,
Yeah, I have.
it's either form or it's like a website, but like flexibility medicine, they actually have to, they have to do, well, they basically peer with they like the insurance companies most times is no. And then if they want to private peer, which is random schmuck, but they don't even know like what the qualifications that spying about it.
I mean, I get it. And you're not provided?
I know for Viagra, you know. But not all drugs are cocaine. So like a Viagra, an example, like I can prescribe, I can myself already 30 year old is way too young to have Viagra, but even my doctor's PhD or he went to some senior school and now it's a hormone drug. My wife, right? And you're like, all right, I'm gonna get medically accepted. It's not about price, it's about he needs it. And I'm going to like we both know this is nothing to do with all I know, but maybe you're on a post or something. I don't think you have to do both at the same time. Because if that's that Viagra case, I guess you don't need to do medical necessity because you're actually doing it, right? Like, yeah, it's true. He's authorized to get it. You don't need to do She is, yeah. She's that, yeah.
But yeah, I just feel bad, like I was in a similar situation where I was yeah, so I don't want to have. Just tell them then that we're going to take a pharmacy right away because the childcare has to process that.
Yeah, I'm going to like I'm gonna get home. House right now. She's like, make sure I don't know because so like my child, she always shows the power of this and oh yeah, she's like offline, but like I know it's like having my life. I look at it and it's connected with it's really weird.
I'd be like, yeah. You know they're
I always told you how I got it and then like I stopped charging it. I called them like, oh, I called them like, yeah, my contract doesn't have an internet. So it's like, yeah, it's free. Like no, like no one's charging anything. Like I'm actually in my lease, it's just nothing about it. So they give you that. I bought initially. I was like, this gig. I'm gigging $1,000. I call it one time. I go to basics, so I try. So I know like, oh, you always do what I do. Yeah, it's all good.
Alright, ready? I got homework today because I heard something that I had never heard before about active duty. I'm gonna call it tricking. But we had somebody who I was talking to, and they were saying that they have had to pay before a copay. Typically, you shouldn't be having a copay unless you end up with a tier 4 drug or sometimes a tier 3 drug. If you go on the outside, like as active duty. So now my mind and my curiosity has been piqued. So I'm gonna call just to see like what's the difference between that, or why anybody active duty would get that copay, so that we can make sure our patients are educated properly, so that they're not mad at you or us, because sometimes whenever they go somewhere and then they find out they have to pay and they weren't expecting it, they get upset. But you can look on that TRICARE formula, look up tool also, and it'll also tell you, like, it breaks it up active duty and beneficiary, and it will tell you if there's a copay, what the copay would look like as well on there. But I'm gonna look that up. Alright, so this is a picture that is showing you essentially all the definitions that we talked about, right? So your uniform formulary is essentially that big box, and then you have your basic core and your extended core formulary medications within that. So those are two subsets of the uniform formulary. And then you have your tier 3 or your non-formulary drugs. So those are typically gonna be a little bit more expensive, and they're not just talking about like, yes, they're branded in generic drugs as well, but when we say tier 3, we're talking about more so like, now I have to do, that triggers me to do one of my forms, either my medical necessity or my prior auth. I have had personally myself where I had a prior auth that needed to be done and a medical necessity on the same exact drug, and they denied both of them, okay? Which then made me pay out of pocket. So there are some of those things where I had a tier 4 drug that I ended up just having to pay for, okay? So you can see where that happens also. Just because you fill out the form does not mean that they have to say yes, okay? And then these are, again, this is a quick summary essentially of what we talked about. So if you like the picture or you like the words, Just pick which one. This is kind of helping you recap all the words that we just talked about. All right, drug development. Lots and lots and lots of money involved in drug development. And now I can personally speak about it because my daughter, I put her in a clinical trial. And so she has the brittle bone disease. It was a random mutation that we were just blessed with. And so they don't have a lot of drugs that are for this condition because it's a very rare condition, right? Like not a lot of people have it. And so we were using, gold standard was to use a bisphosphonate, bless you, that you would typically use for like osteoporosis and other things, off-label for kids or adults who have osteogenesis imperfecta or brittle bone disease, right? So there's not a drug yet that is specifically made for that. So they started and they tested in adults, and they're like, okay, they double-blinded it and they're testing. And then our study was gonna be double-blinded to where we were either gonna get the bisphosphonate, which was what she was already doing, infusions that way, or she was gonna get this new drug that was like really amazing. So they randomized us, and then they decided in the kids that it would be better to just let the parents know what their kids were taking so that the parent would be like, all right, am I on alert now for more fractures or not? So they ended up unblinding our study, so we got to know. Plus the kids are super smart and they could taste the adults were tasting, not the kids, the adults. They were tasting if they were getting, because with the adults, they gave them the med or they got placebo. And so whenever they were giving them like the dextrose, they could taste sugar. And so they were like, I don't have the real drug. And they were all right, that like they didn't have the real drug, so then their blind was a horrible blind, okay? So you're doing all of these things and studies, and so it takes a lot of research before you even get people involved because you wanna make sure that your blinding is good, you wanna make sure your randomization is good, because when you bring something to the market, you want your data to look good. You can't go back to the FDA and trick them. They're smart, okay? These people get paid a lot of money for a good reason. The drug companies also have very good and smart researchers on their side. And like we said, this can take up to 10 years for a drug to come to market and billions of dollars. So like for my daughter, if we weren't in the military, they would fly us there, they would pay for her hotel, they pay for her food, they pay her every time they give her an infusion, which we have to go every single month. So she gets paid every single time we go. So she's one person in the trial, right? Think about how many people. Oh, and they also pay for 2 people to go with you because they're kids, right? So somebody has to go. So you're paying for people to fly from around the world to get to somewhere, right? Not to mention if somebody has side effects, right, while we're doing these studies, my happy pill doesn't work, and instead I make somebody like an angry murderer, I have to pay for that, right? So you have to like look at all of the things that go into this. So it takes a lot of time and a lot of money for things to get through clinically. If you have medication, so this is a typical phase, this is typically how long something takes. But think about like when we had COVID. Think about if you have like what's called an orphan drug, right? So there's a disease that's not very common. We speed them up through this process so that people who have that disease have some type of medication. COVID, we had nothing, right? So we sped through this process. So our data, we're like, So now you see a lot of post-surveillance studying going on, or several different studies. Oh, do you have this wrong after the COVID shot? Is this wrong? And you're like, gosh, well, I should have just got COVID, right? Like that's how some people are feeling. When in actuality, a lot of people with underlying health conditions, if we didn't hurry up through this process, they could have died, right? So you're just trying to figure out what to do. So with our acts and with us talking about drug development, we go through these 4 phases, okay? Before we even get to the clinical trial, you have your preclinical stage. In this stage, this is where you're saying, I found something, right? Like I have to do this IND or an investigational new drug application. I found something, I want to test it, I'm submitting this to the FDA, right? And then I have to get my stuff together. I gotta get my trial together. What do I want this to look like? What does my protocol look like, right? Like what is my screening criteria, what's my inclusion criteria, my exclusion criteria, you know how y'all are doing those PICOs and all that? This is like what you're gonna look at when you're doing your paper, okay? So this is essentially kind of things that we also look at when we're setting up trials. And so they get that approved, and then the FDA is like, all right, go ahead to phase 1. So when we do phase 1, there's a very small amount of people, and they're typically healthy, right? We start off small. We don't just go in super cocky and confident that our drug works. We're like, let me get a healthy person, and let me make sure that my values or what I think my expected drug dose should be isn't toxic. Is my drug tolerable? I'm not seeing if my drug works yet because my patients are healthy. There's nothing wrong with them. They don't have the disease. They're perfectly fine. I'm just trying to make sure that I'm not killing them with this dose and my dose is safe, okay? So healthy volunteers is your big thing, and tolerance and toxicity is your next big thing when we're talking about our phase 1, okay? Everybody is healthy, and it's not a lot of people. When you're looking at phase 2, now I'm like, okay, is my drug effective? Does it work? So I'm still on a small scale, several hundred, but small scale, right? It's not thousands. I'm still on a small scale, and these people are gonna have whatever I'm trying to treat. Because now I need to see, I figured out my dose that I need to do, I know that it's tolerable, I know it's not toxic, I know they can take it, I figured out my dose, now I move to phase 2 with my patients who have my disease, and I'm like, does this work? Is it effective? Okay, so that's what I bolded for you. There's more words in there if you want to read them, but that's what I bolded for you so you can remember. This is where we actually get that final drug that we are going to end up saying, this is what's going to phase 3. Now I can package this, right? Because I've done the footwork. I know that I'm not poisoning anybody. I know my upper limits, right? And now I also know it does what I said it's going to do. Then when I go to phase 3, I'm opening up several different centers, large hospitals. So like my daughter's study, it's Houston. We go to Houston, but there's Fort Worth, there's states up north, there's other things on the East Coast. Like there's several different centers within the United States that are all trialing this same drug, right? Because we're getting different samples, different people from different places to say, does this work, right? So now I'm looking at this, I want to continue to see, now that I have a bigger sample size, is this safe and is this still effective? Did I package the right drug? Did I present the right thing to you? Okay? So safety and efficacy is what we're looking at here. Now we're also trying to see what are the common side effects that I see. So after phase 3, if I pass phase 3, when we look at a leaflet and when you hear those commercials and they start rambling off all those side effects, they're getting that from this part of our clinical trial. This is where they're finding out stuff. When you look at phase 4, it's gone to the market now, right? So that's why it says post-marketing surveillance. It's gone to the market. All of us have access to this medication, right? You can now prescribe it to whoever you want. But remember when we talked about that the MedWatch, right? Post-marketing surveillance is very important, especially with our newer drugs. Because I might not have captured everything in that phase 3. I might not have gotten every single side effect because I only had a couple thousand people. Now, anybody who has this disease, several hundreds of thousands of people, right? Millions of people can now use this medication. Now what are we seeing? Because my sample size is now humongous, right? So now, what are the common side effects that are coming in? Is it anything that we didn't catch in phase 3 that we're now going to catch in phase 4? Where you, where me, the patient, any of us can go and report it and say, hey, I'm experiencing this. And if enough people do that, they can say, hey, this is probably linked to that med. Or we've seen things where we could pull it off the market. Like, oh, it was fine when we were in trials, but now we're seeing that this is giving people heart attacks. Yank. Okay? So that's why it is important for you to report if you do see something. Okay? So detect serious, unexpected adverse effects, and then we're still looking to make sure that it's effective. All right? there's a video that's on here that talks about studies and how they have, it's a TED Talk, and how there's like publication bias, and again, depending on who funds it, or the drug company who's doing it, they may manipulate certain things in their protocol to get the results that they want so that their drug can go to market and so that it sounds great and then it may not be, right? So that's our job, is to look through those studies, to look through that data. I usually, when something is brand new, I typically will not do it, but whenever they said, oh, we have something that we could try, I was like, looking at my husband, like, what do you think? He was like, you're gonna do that? Because I am so like, not risky at all, okay? But to me, this one was worth it, and it's been working really, really good. So you have to be able to read through like the rosy lenses, right? And don't take everything for face value. That is your job now, because somebody is relying on what you're learning to take care of them, because they have no idea. I'm a whole pharmacist, and my parents can barely say medication names that they take, and I'm like, learn the name. Lispro, like my friend's taking Lispro. Do you know what I can tell her about that? That's not what it's called. Is it lisinopril? Yeah, that sounds like it. Okay, cool. Right? Like, you are the expert. You are going to educate them. They're going to trust you. Okay? So when we have these drugs that go through these trials and they get to that post-marketing phase, you still got a job to do. And it's up to you as a provider to say, hey, like, let's see what happens with this drug. Like, I had a doctor one time, I was like, I just saw this thing on the commercial and I was laughing at myself. I was like, I sound like patience. So I just saw this thing on the commercial, what do you think about it? Oh, I'm not trying that until at least a couple of years. I gotta see what this post-marketing surveillance does. Okay. And you'll have a lot of providers, like, I just like to go and talk to them about stuff and see like what their thought process is. So depending on who your preceptors are, depending on who you are gonna be as a provider, you can take whatever, look at that you want to. Take whatever your stance is and stand on it. This is just another picture, showing you like that timeline that we talked about. So you see like roughly 8 to 10 years of a drug actually hitting the market, which is after that phase 3. And then that's when we have our post-marketing surveillance. And then once that patent expires after that 20 years, that's when you can see a lot of those generics start to pop up, because now they're no longer protected. But you see they're wasting most of their patent, half of it almost, while they're in clinical trials, right? So you have that exclusivity, but realistically it's usually only like 12 to 10 years that they have that, okay? The orphan drugs that I was telling you about, emergencies, things like that, we'll see drugs they're gonna skip through this a lot quicker. So you'll see some of this stuff, like that COVID vaccine, we saw that in months, right? Like it didn't take 10 years. Okay, so you'll see in different orphan drugs, some of them may take 2 to 4 years. It depends on how serious that disease is. Okay. All right. Quickly to wrap this up, we have some references that you can use. I like the FDA website. Sometimes it can be a little bit overwhelming because it has every bit of information that you could possibly think of. It'll show you somebody's IND, so their investigational new drug application. It'll show you their monographs, like all the studies that they did in their clinical trials. Like you can see literally almost everything that you want to see. So when you're looking at a monograph, this is something that's called a package insert. In the pharmacy, on certain medications, especially if it's the patient's first time getting that medication, you know how you open that big old leaflet and it has all the information that you can, not a whole bunch, but digestible information for your patient to see. That's your monograph, okay? And so that's what we typically give to our patients. If you have a brand new bottle of medication, and it has like a pack, like the monograph glued to the bottle, that's typically for healthcare providers sometimes. Like the language isn't as patient friendly as the ones that you'll see from like CVS or Walgreens that are tailored towards the patient, because they know the patient is reading that. The manufacturer of like our big pill bottles, those typically are going to have things that are geared for me and you, because we understand ADME, like we're going to know all of those things. And so that information makes more sense for us to make educated decisions to give this to our patient or to not give it to them, okay? So your monograph is just something that must be in any of your medications that are going to be packaged. You have to have them. Our library is pretty good. They keep changing logins for things. So if you do need access to the book, I think that login and the access to the page has changed. Access now to LexiDrug has changed, like they keep switching over things. So if you need help signing into any of those applications, please go over there to get help with that. I would definitely suggest LexiDrug when you're doing phase 2. And if you're studying now, you can glance at it, but it has a lot more detail than what I'm gonna go into with you all, okay? But LexiDrug is a very, very good resource. You'll also hear it called LexiComp, okay? The LexiComp has more information, whereas LexiDrug is just specifically about the drug. Up to Date is very good. Be careful with Up to Date though, because it'll have a lot of providers' personal opinions and like what they typically do in practice. So just try to always, what I like to tell people, your best drug reference is gonna be looking at like a guideline to see like what do you use for that disease state, and then I love LexiDrug or LexiComp. If I want more information on like clinically, like what's happening clinically, like how am I practicing, then you can look at Up to Date for that. But just be careful again, they tell you about the writers, so look at the writers' information and kind of be like, are they biased or are they not biased, okay? All right, quick review. Y'all ready? Candy time since we sleeping. We know all of these answers because we went over them yesterday, right? Who is responsible for our patient care? You are, not me. Not me. What is a prescription? That order, right? I have to write it. I have to individualize that to my patient. Everybody doesn't get the same thing. Okay, pay attention to the side effects. Pay attention to interactions. If there's drug interactions, if there's a black box warning, if I'm pregnant, like you have to look at all of those things whenever you're ordering that prescription, okay? So look at your patient as a whole. It is individualized for that patient, all right? Is the legend drug, what is a legend drug? Prescription, that's another word for it, right? And then our OTC is over the counter. So they are not the same things. And then where am I going whenever I'm reporting that side effect or that ADR? What was the website? FDA MedWatch, okay? Now, what phase do I typically see where I may have to report an adverse effect via MedWatch? 4. Okay? Remember, that's the post-marketing. Now it's on the market. I can go in there and I'm going to go ahead and write it. Any of the adverse effects that they're seeing prior to it coming to the market, that is going to be up to that drug manufacturer to report those. Okay? They will put that in their packet that goes back to the FDA. And so that's where when we're looking at our monograph and we see all the side effects, that's where they get those from. They get those from the studies. But the post-marketing things typically are going to come from you guys, from us, reporting and saying like, hey, this is also happening, all right? So MedWatch, how many schedule categories are there for our drugs, controls? 5. Do we have refills on controls? Okay, 3 through 5, yes, right? 3 through 5, we have refills. How many refills?
5
For how long? 6 months. What about my C2s? Do I have refill? If I want to write for my C2s, what is the quantity options that I have? 30 or 90. 90 is for my patients who are on what type of C2? Maintenance. Okay. What else do I want to ask you about C2s? Who monitors C2s? Okay, DEA. What is my most of the one with the highest abuse potential that I could prescribe? Okay. All right. What regulation governs the transference of patient health information? All right. Okay. So I'm going to try to make you guys some questions. What I'll do, since this is your first exam, I'll probably do a review for y'all, and I'm gonna keep going today so that when we do have extra time at the end, it's gonna be during the class. Like, we'll do the review during the class, we'll probably play a game or something, I have to see what I have, okay? So, I'm gonna be nice for exam one. Okay, let's open up, not your calculations, because we're gonna do that tomorrow. Fundamentals. All right, so when we're looking at our fundamentals of pharmacology, this is gonna look very familiar because y'all have already seen this before, okay? You saw some of this when you did biochem. And so I'm gonna go through some of this and try not to like over-explain it to you, okay? All right, here are your ELOs. And then let's do a recap to see some of the things that you still remember. How do our drugs get to the target site in our body? Like, what's the process that it has to go through? I think I heard, yes, Abby, right? Is that what you said? Okay, so remember, we have to go through Abby, right? Our absorption, distribution, metabolism, elimination. Please remember that because it does come up again. We're talking about that this semester, well, in our junior class, they're like, I don't even remember what Abby was, okay? Don't forget it because you're gonna see it again. How many half-lives does it take to reach steady state? Y'all are so good, we don't need to go do this lecture. I'm just kidding. First pass metabolism experience with IM and IV. So when you're looking at this, understand that it goes through the portal vein, absorption to the liver, and then that's where it can have some first pass occur. But when we're talking about like these, most of the time you're not going to see it, especially with our IV medication. True or false? A prodrug needs to undergo metabolism to become active. What happens to a base in an acidic environment? Is it absorbed or not absorbed? All right, not absorbed, right? So when we think about this, remember like dissolves like, okay? It's kind of how I try to remember it. Are all metabolites inactive? Yes or no? No. What kind of metabolites can I have? Like, do they have, can some of them, I'll just show you, I guess there's no way to really say it, right? So I can have a metabolite that is active. I can have a metabolite that has more activity than my parent drug that I gave them. I can have one that has less activity, but it's still active and it's not completely inactive. It'll go through metabolism again, and some drugs can go through metabolism a couple of times before it then becomes inactive, okay? So just don't think that because something got metabolized that it's inactive. That is not always the case. All right, here are some definitions. Not gonna really beat you with this one. Big one that I want you to go over and remember is that your pharmacokinetics is essentially what the body does to the drug, whereas your pharmacodynamic is what the drug is gonna do to the body, right? So that's the difference between the two that we kind of talk about and that y'all already know. Because y'all answered all my questions, right? Okay. So this is again just telling us that definition, but it has a cute little picture on it, right? My pharmacokinetics versus which is at the top, right? So what my body is doing to that drug, how my body is getting that drug into the system versus my pharmacodynamics, which is what the drug, and remember like dynamics has a D in it, so what the drug is now doing to my body, okay? So when we talk about ADME, we have our absorption, distribution, metabolism, and elimination. So if I take a medication by mouth, it has to go through these processes so that it can get to that site, and then my body will say, all right, I used you, don't need you, and then it's gonna eliminate it, right? Some drugs are eliminated a lot faster than others. I talked to y'all about bisphosphonates super briefly, and we'll talk about them next semester. When we think about a bisphosphonate, it can be in somebody's body for over 10 years. Okay? That's a long time. Okay? Is it still being eliminated? Absolutely. But it can stay just hidden in that bone for up to 10 years, so far that we know. Okay? So when you think about elimination or you think about absorption, just when we go through this, remember all the things that can affect these things while they're happening, right? What can affect absorption? What can affect metabolism? What can affect elimination? What if my kidneys are damaged? I'm not going to eliminate properly, right? So thinking about all of those things, and then that will feed into, all right, is my half-life changing because of this issue? Okay, so we'll kind of go through those things and touch on them again. When we're looking at our medications, the big challenge is how do we get that drug to our site of administration, like our site of action? What do we want it to do? What are we trying to make it stop? What are we trying to make it stop, essentially, sometimes? Or we could be using a drug to make it like activate something, okay? Depending on what type of drug it is. So we have to worry about ADME, so absorption from the site of administration, whether it is me injecting it or me taking it orally or a patch, a cream. There's several different ways in which I can administer a medication. Once it gets absorbed, then I have to get it to be distributed around my body to that site that I need it to go to so that it can perform its action. And then when we're talking about metabolites, that's what we kind of just went over briefly, right? But I have my active or my inactive ones, depending on what drug is given to that patient. And then elimination is me getting it out of there, right? I'm done with it, I've used it, I don't need it anymore, okay? So this is just a chart showing you that clearly this person took an oral medication, right? Because it's having to go through that absorption phase, and you see the concentration is slowly going up as it continues to get absorbed, and then it's distributed, and then metabolism is continuing to happen while elimination is happening, okay? And then if I took another dose, we would see another peak. But if I don't take another dose, you see that I'm gonna fall outside of that minimum effective concentration, okay? So your therapeutic range is very important because we have some drugs where this is very narrow, okay? So like if I have a medication, what about him? Now he's Colonel Johnson, I heard his name just now. So we have this, right? So this is our therapeutic range. This is my maximum that I can stay under and be safe. If I go out of here, I'm expecting more ADRs right here, right? I'm expecting more issues. Whereas if I'm under here, I still have issues because I'm not going to get the effect that I want. The drug, the amount of drug is not strong enough to produce my desired effect, right? It's not a high enough concentration. This is my sweet spot. This is where I want to be. I'm happy, okay? You have some drugs that have wide therapeutic windows, and then you have some that have very narrow therapeutic windows. The ones that have narrow therapeutic windows are the ones that are most deadly. Because if one thing gets off and it goes outside of that range and it hits that maximum safe concentration, now you have toxicities, okay? And depending on what drug it is, it can kill somebody. And a lot of those ones with the narrow therapeutic range, we have a lot of monitoring that we do for them. Digoxin is like a big one. We talk about warfarin, like you'll monitor lots of different things on some of those drugs. But digoxin is like one of the biggest ones that you'll see. All right, looking at your PK parameters that we have, this is just understanding that our dose is coming from those PK parameters. So you need to make sure that all of these things are kind of being taken into account so that your drug does get to where it's trying to go. So what we're talking about when we're looking at our PK parameters are going to be all of these different things here. How am I giving this medication? If I give this medication, is it going to go through first pass so much? Is it going to be so extensive that the concentration is going to be so low and it's not going to hit enough of those receptors to get the response that I want? Possibility. So then that's saying to me, I can't give this medication orally, I have to give it IV, right? Because I got to get past that first pass metabolism. So this is how they look at these PK parameters, or they use this PK parameters when we're talking about developing drugs, okay? So you're gonna look at all of these things to say, all right, my bioavailability, how does this drug accumulate? Okay? How is it stacking up? Is it like a one-to-one, like I take one and then I have that slight increase? We'll talk about these again. Y'all have already talked about it, but like that accumulation is also a big thing because if I accumulate too much, now I'm again outside of that range and I'm not safe anymore. Okay? We also think about accumulation, that will also tell you how often someone is taking a medication. Okay? So like whenever we say every 8 hours, we're typically doing that because we took our oral med, right? It peaked, and then we started to have that metabolism and that elimination, and it's falling below my MIC or my minimum effective concentration. Okay, it's falling below that. So then when I say every 8 hours, I take my next dose, I'm gonna go back up, back into my therapeutic range. So that's how we typically also get our frequencies. It's from this accumulation and that clearance and elimination that's happening as well. Okay, so lots of different balances that are going on at this time. All right, I went ahead and tried to like taught this for several semesters and everybody always gets confused, okay? This is a very important slide because you're gonna look at how your meds are effective or absorbed in certain areas based off of if they're acids or bases, and then looking at the environment that they're being absorbed in. So I really want you to kind of focus on what the words are saying. So when we think about hydrophilic, we love it, right? I love water. So when I look at this, because depending on what literature you're looking at, I added in every single name that you could potentially call it so that you can see it on one page and refer to just one page. Because again, some places you look and they'll say, oh, it's charged. And then other places you'll look and it says it's unprotonated. Like, can we stick to one word, please? Okay. So all of these are essentially synonyms when you're thinking about your acids and bases and are they going to be absorbed or are they not going to be absorbed, okay? So I want you to just like, that's why I put equals, like these are all the same things, okay? And then when we look at our lipophilic, right, fat, lipo, you're uncharged, you're unionized, you're protonated, you just out there, you're free, there's no baggage, okay? You're not charged up, you're just okay? And then you have protonated on that side. So when we look at this, just looking at in what I put in bold, right? If I have a weak acid in an acid, I have absorption, right? Because these are alike. If I have a base in an acid, these are not alike. So think about a magnet and it's just repelling, right? It's not getting absorbed, okay? Same thing here, if I have acid in a base, I'm a magnet, I'm opposite, so I'm repelled, not absorbed. Versus that weak base in my basic medium, now I'm absorbed, like to like, okay? So that's why like absorbs like, all right? When we're looking at this, this is another way for you to say like, if the pKa is greater than the pH, right? So that's, I would give you these values if I were to do something like that. So if your pKa is greater than your pH, then your protonated form predominates. Protonated is a synonym to what we talked about with what? Lipophilic, uncharged, easily going to be absorbed, okay? So that's why I tried to put this so that you can have everything together and it's not all separated, all right? So that you can remember this terminology. So if you see these words, you're like, all right, if I see that my pKa is greater than my pH, then I know that I'm protonated, got it, absorption. Okay, so start to associate these words with each other. And so the name of this slide is remembering here, like absorbs like, and then this first part here, your pKa greater than pH is protonated form predominates, therefore I have my absorption. If this were flipped the other way, then no absorption. Okay? Everybody good? All right. This is a picture showing you exactly what we just talked about. Okay? So when we're looking at this, I'm telling you, hey, I have ibuprofen. This medication is a weak acid. All right? it is in another area that is acidic, all right? What am I expecting to happen? It's gonna go ahead and it's gonna go through, right? I'm good to go. I'm a weak acid, I'm in an acidic environment, we're great. Like absorbs like, right? Now, in this situation, I'm telling you that ibuprofen is a weak acid, it's in the small intestine, okay? So my pH is now a little bit higher, all right? I could also do this another way and say, oh, look at my pKa and my pH. So I can use that word, the words that we talked about that was at the bottom previously. Or I could say, what's going on with my light absorbing light, right? So in this situation, what do we think is going to happen in the small intestine? Right? It's going to hate it. It says no thanks. Magnets, bless you. Okay? All right. We are okay? We're okay. Okay. All right. Now, this is going to talk about filtration. You're going to hear this again next semester. So when we talk about our drugs and how they're going to go ahead and come in through our body to either get reabsorbed or secreted, that is going to deal with our secretion and going through the glomeruli and the kidney. Like this is our filtration system, right? This is cleaning up everything. Just think of our kidney as our net to like, if you were digging for gold and you're trying to sift through all the sand at the beach and you like dig in there, this is the kidney. It's like getting rid of everything you don't need, keeping the good stuff, right? What do I need? So that's what we're talking about when we're looking at our absorption. Reabsorption would be something that went into one of these ducts, right? And my body was like, hold up, I need that, give it back, okay? And then it gets reabsorbed back into the body, okay? Instead of getting excreted out, which makes sense, right? Now I'm going to urinate it or poop it out. All right? Now, when we look at our pH effects of our medications, right? If you're talking about urine, which is mildly acidic, and then I have something like sodium bicarb, which is going to make urine more alkaline or basic, this is going to increase the elimination, right? So again, think about the basic principles that we already talked about. If I had a like-to-like situation, then I could have potentially reabsorbed it. But because I didn't and I'm magnets, right, I'm getting rid of it. I'm eliminating it, okay? So the same thing here with the acidification. If I acidify it and there's a basic drug there, I'm going to do the same thing. I'm going to eliminate it because now these are two different things. If I would have said that I made it more basic, then I would have kept more of it. I would have been able to reabsorb more of it. Okay? So, in this situation, instead of having like to like, I had dislike eliminates dislike. So that you can kind of remember it in your head. Alright, with this was just a quick check-in. So, us kind of walking through this, you have the sodium bicarb, and then if you had a weak acid, like ibuprofen, what would happen, okay? So this could be an exam question, like how I could word something like this. Or I could just give you pHs and pKas, okay, and say like, hey, what are we doing with this, all right? So again, go back to that slide to remember what we're doing with our terminology as far as like unprotonated, protonated, because that's where a lot of people get confused. I don't think that is people forget the concept. It's that we forget all of the different words and what they mean. Okay? So just print it out and keep looking at it. Alright? And then again, this was just the other part. So a charged particle will not be absorbed, therefore it's going to be excreted because we were talking about being in that duct, in the tubule of the kidney. Okay? Alright. We got 3 minutes. Keep going. Okay, routes of administration. So when we look at our routes of administration, y'all have gone over this already. You have your oral, your buccal, which is where they just kind of put it in the cheek. Sublingual is when they put it under the tongue. And then rectal, of course, you put it in the rectum. when you're talking about sublingual, a lot of people don't like the taste of things sometimes that dissolve under their tongue. If that is the case, then see if we have an oral formulation of it. It's sublingual so that it can get to the site faster. All right? So if they're swallowing it, it kind of makes it a little bit more difficult versus if they take it how they're supposed to, which is slowly letting it dissolve underneath their tongue and extend that action. Your parenteral or non-alimentary routes is anything that is not given by mouth, okay? So any of these other options that are not given like orally and they're not gonna go into your alimentary canal, so like your throat. It's not going down there. It's not going anywhere in your mouth area, okay? Those are our different ones. Bioavailability, y'all are good on bioavailability. Stands for, or the abbreviation is an F, and this is the amount of drug that's actually gonna reach the site of action, right? This is where we want our drug to actually work, and we want it to be in its active form whenever it does this, okay? So we're worried about first pass. First pass is a huge determinant when we're looking at this, and then the amount of absorption. Was that the right route for my drug, right? Like all of this comes into play when we're talking about getting it to the site that we need it to actually work. And then when we're looking at this, just remember, we always say 100%, but our IV drugs are really close to 100%. So for this class, F equals 1, okay? When we talk about, and most people, when we talk about any of our IV drugs, we're usually gonna say the bioavailability is 100%. We're usually good, okay? We'll start here tomorrow, and then we're gonna do calculations. So if I don't finish the rest of these, and we'll keep this pace because this, again, y'all have already seen a lot of it, because we shared these slides and like kind of manipulated them to our own classes. So tomorrow we'll do this, and then the second half we're gonna do the calculations, and then if we don't finish this in the first half, we'll go back to it on Friday. I think it's the day. I don't know what day it is. Okay? Have a good day, y'all.